The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, now moving on to your lower extremity, again, starting with the bone. So we'll start with the femur, okay, which happens to be the strongest and longest bone in the body. Okay, sige, let's go to the picture. So your femur is made up of a femoral head. Okay, so this one articulates with the acetabulum to form your hip joint. Okay, at your head you can see a depression, okay, known as your fovea capitis. Okay, so this is where the ligament of the head of the femur or your ligamentum teres attaches, no, to facilitate the transport or entry of your obturator artery, no, to supply your femoral head. Okay, followed by the head, you have a neck, commonly a site of fracture as well. You have the greater and lesser trochanters, okay, here, and then anteriorly it's connected by your intertrochanteric line, okay, while posteriorly it's connected by your intertrochanteric crest. Okay, next, no? So you have a shaft here, and posteriorly along its shaft you have a roughening known as your linea aspera. No? It's a common origin for your adductors. Okay, so your linea aspera distally will flare out to form the medial and lateral supracondylar ridges. Okay, ano pa? Okay, you also have your adductor tubercle here. Okay, attachment of your adductor magnus. Proximally you have your gluteal tuberosity, no, which will be the insertion of your gluteus maximus. Okay, and so you have your medial and lateral condyles, okay, and your intercondylar notch. Okay. Okay, next. No, one measurement that we utilize in your femur is the neck shaft angle. Okay, so this is your neck. No? So midline of the neck, and then midline of the shaft. Okay, so the angle form will be measured usually or normally it's around 160 degrees in the young, and around 125 degrees in adults. Okay, so changes in your neck shaft angle might indicate a pathology. If the neck shaft angle is decreased, no, less than 125, it is known as your coxa vara, no, commonly seen in femoral neck fractures. Okay. However, if the neck shaft angle is increased, it's coxa valga, no. Example of the condition wherein we see a coxa valga is your congenital hip dislocation. Okay. So your femur articulates with the head of the femur and the head of the femur articulates with your acetabulum to form your hip joint, no? Unlike your shoulder joint, no, mas maganda yung articulation niya, no? Kasi mas covered yung femoral head by your acetabulum. However, it's still further deepened by your acetabular labrum. So just like your glenoid labrum, it deepens the cavity of the acetabulum. Okay? So next, no? So this is your acetabulum, and along its inferior aspect, you see the deficiency, no? It's known as your acetabular notch. Okay? And again, your hip joint is a synovial ball and socket joint. Okay, so clinical correlation, no? Hip dislocation. So, you have congenital and acquired. Okay? So, your congenital hip dislocation, it's more commonly occurring in girls at least 8 times, no, more often as compared to boys. Usually, they complain of inability to abduct the thigh. So, limited hip abduction is actually a characteristic of congenital hip dislocation. Okay? They have shortening of the limb and they have positive Trendelenburg sign. Okay? So, those are signs of congenital hip dislocation. Okay? Next, acquired hip dislocation could be traumatic, no? And the more common direction of hip dislocation is posterior, no? More common or most common direction of hip dislocation is posterior, wherein the hip is flexed, adducted, and internally rotated. Okay? And usually it's associated with a sciatic nerve injury, no? Because your sciatic nerve lies posterior, no? Posterior to the hip joint. Okay. Moving on to the muscles. So, which of the following muscles is a flexor of the thigh? Okay, adductor longus, iliopsoas, gracilis, obturator internus. Okay, answer is iliopsoas. No, it's the main hip flexor of the thigh. Okay, next. No, ito tinanong to ng 2022. No, muscle that originates from the superior ramus of pubis and inserts at the upper end of linea aspera. Okay? Sartorius, iliacus, psoas, pectineus, or rectus femoris. Okay? That is your pectineus. Okay? So this table, okay, is actually high-yield, no? Because Sartorius has already been asked in the past either 1 or 2 exams, no? So your Sartorius originates from your ASIS, no? Anterior superior iliac spine, okay? And it inserts at the upper medial surface of the shaft of tibia, no? Together with your other pes anserine muscles, no? Together with the other pes anserine muscles. Okay? So that includes your Sartorius, okay, gracilis, and semitendinosus. Okay, so these muscles are your pes anserine muscles, and all of them will insert at the upper medial surface of the shaft of tibia. Okay, so your Sartorius, it flex, abducts, and externally rotate the hip, and flex and internally rotates the knee. Your iliopsoas, no? So your iliopsoas inserts at the lesser trochanter, no? And acts to either hip flexion or trunk flexion. Okay? And ito yung tinanong, no? Your pectineus, recently lang din tinanong. Your pectineus originates from the superior ramus of pubis, and then it will insert at the upper end of the linea aspera and is innervated by the femoral nerve. Okay? And it acts to flex and adduct the thigh. So far, sa anterior compartment of the thigh, wala pang tinanong, no? So, these are your quadriceps muscle. Okay? So, your quadriceps muscle, they have a common insertion, no? So, your quadriceps tendon will attach to the patella. Okay? And then, it will continue to become your ligamentum patellae or the patellar ligament or the patellar tendon to insert in your tibial tubercle. Okay? All of them have a common innervation, the femoral nerve, okay, and acts to extend the knee joint. Okay? Quadriceps tendon, ligamentum patellae, all of them femoral nerve. Okay? Again, all of them knee extension. Next, which ligament of the hip is Y-shaped, okay, and checks hyperextension of the joint during standing? Okay? So, ligaments of the hip, actually, 2020 naman ito tinanong, no, during our board exams. Okay? So, this question, Y-shaped, and it limits hyperextension. Okay? That's your iliofemoral ligament. Next, ligament of the hip joint that limits adduction naman, okay, it's your ligament of the head of the femur. Okay, so let's discuss each ligament. So your iliofemoral ligament, it's the Y ligament of Bigelow. No? Why? Because definitely it's Y-shaped, no? Kaya siya Y ligament. Okay? It's a strong ligament and prevents overextension or hyperextension during standing. It also limits external rotation or lateral rotation. So this ligament is very useful, no? Kaya merong mga spinal cord injury patients, no, that can stand. Okay? It's because of this ligament. It's very strong that patients can use it, no, to do hip extension, no, in standing even without any motor activity. Okay? So that's your iliofemoral ligament. Your pubofemoral ligament, okay? Yung pubofemoral ligament, it's here, no? It's inferiorly located inferiorly. So what will happen, no? Inferior and anterior, no? Siya yung location. So it will limit, number one, it will limit abduction, no? It will limit abduction as if when you're doing this motion. So this is abduction, no? Masu-stretch siya. And since anteriorly located siya, it will also limit hip extension. Okay? So, your pubofemoral will limit extension, abduction, and it will also limit external rotation. Okay? Next, your ischiofemoral ligament, okay? Nasa likod naman siya. Okay? Nasa likod, and then it will insert anteriorly. Okay? It will limit naman extension and medial rotation. Okay, so what's the common denominator of the hip ligaments? So all of them will limit hip extension. So all hip ligaments will limit hip extension. Okay? Yeah. Okay. Other ligaments, you have the transverse acetabular ligament. Okay, so hindi siya kita dito, no? So your transverse acetabular ligament, okay, it's formed by the acetabular labrum, no, to fill in or to make the acetabular notch a tunnel to facilitate passing off the blood vessels and nerves, no, to enter the joint. While your ligament of the head of the femur, no, it's here, no. It's the ligament of the head of the femur or your ligamentum teres. So it limits adduction. Okay, so it limits adduction, partially limits adduction. So, it's here. Yan. Okay, moving on sa femoral artery. No? So, your femoral artery ay maraming pinagdadaanan. Okay? And isa-isahin natin, no? Kung saan siya dumadaan. Okay? So, your femoral artery, let's start from its origin, no? So, from the aorta, okay, you have the common iliac artery. Okay? Your common iliac will divide into external and internal iliac artery. So, your internal iliac will go sa internal organs, sa pelvic organs. While your external iliac will continue to supply the lower extremity. Okay? So, this is your external iliac artery. Okay? So, your external iliac artery will continue to become your femoral artery beginning at the inguinal ligament. Okay, so at the inguinal ligament, it will now become your femoral artery. Okay, so your inguinal ligament is attached to your anterior superior iliac spine in the symphysis pubis. Okay, so andito. Yan, ito, no? This is your inguinal ligament. Pagdating dito, femoral artery na si external iliac artery. Okay? At ang unang pinagdadaanan ni femoral artery is your femoral triangle. Okay? So, femoral triangle, superiorly, it's bounded by the inguinal ligament here. Okay? Laterally, this one is your sartorius. And medially, this is your adductor longus. Okay? Next. So, what are the contents? No? This is your femoral nerve, artery, femoral vein. Okay? You have an empty space and you have your inguinal lymph nodes. So, the mnemonic here is navel, no? Navel. So, nerve, artery, vein, an empty space, and your inguinal lymph nodes. Okay? Navel. That is from lateral to medial. Okay? So, yan yung unang dinaanan ni femoral artery. However, within the femoral triangle, okay, so you have a femoral sheath. Your femoral sheath is a downward protrusion of the fascia transversalis and fascia iliaca. Okay? Your sheath will only cover AVL. Okay? So, hindi na isama si nerve. So, kasama si femoral artery, femoral vein, and lymph vessels. Okay? Can you follow? So, your femoral sheath is still divided into 3. Okay? Lateral, intermediate, and medial compartment. Okay? So magiging lateral compartment, si femoral artery. Okay? Within the intermediate compartment, it includes your femoral vein. Okay? And then the medial compartment contains the lymph vessels. Okay? Your medial compartment of the femoral sheath is also known as your femoral canal. Okay, again, femoral triangle, navel. Okay, within the triangle may sheath, no? Pero hindi kasama si nerve. Okay? Then the medial compartment, it's known as your femoral canal. Okay? However, again, no, sa femoral canal, proximally or the upper opening, okay, you have your femoral ring. Okay? It's normally filled by a plug of extraperitoneal fat called the femoral septum. Okay? What's the clinical implication? It is a potential site of herniation, okay, along the femoral ring. Okay, next. Your femoral ring, what are the boundaries? So, this is the artery, this is the vein, this is your femoral canal, the medial compartment. Okay, yellow. So, anteriorly, it's bounded by the inguinal ligament. Okay, posteriorly, it's bounded by the pectineus or pectineal ligament. Laterally, you have the femoral vein. Okay, and medially, you have the lacunar ligament. Okay, so that's the boundaries of your femoral ring. Okay? So, tapos na tayo. Again, this is your femoral triangle. Okay, merong sheath. And then yung sheath, merong canal. Proximally, merong ring. Okay? So, tutuloy na ngayon si femoral artery sa ilalim ng sartorius. No? Para makababa na siya. Okay? And the femoral artery will pass through the subsartorial canal, also known as your adductor canal. Okay? It is located at the apex of the femoral triangle. Okay? So, what are the boundaries? You have your sartorius, okay? Your vastus medialis, wala dito sa picture. You have your adductor longus and magnus posteriorly. Okay? Ano yung contents ng femoral canal? You still have an artery. You still have the vein. You still have the lymph vessels. However, may naiba. Okay? The nerve, hindi na siya femoral nerve. Okay? Ito na ay branches ng femoral nerve. Okay? Your saphenous nerve and your nerve 2 vastus medialis. Okay? Again, not the femoral nerve anymore, no? Only the branches. Your saphenous nerve and the nerve 2 vastus medialis. So, in summary, okay, sa femoral triangle, you have navel, nerve, artery, vein, lymph nodes, lymph vessels. Sa femoral sheath, hindi nakasama si nerve, no? So, AVL. Okay? And then, going through sa adductor canal, AVL pa din. There are nerves, pero branches na ni femoral nerve. Okay? So, the saphenous nerve and the nerve 2 vastus medialis. Okay? And you have your femoral canal, no? So, the medial compartment, you only have lymph nodes or lymph vessels. And proximally sa upper opening, you only have the lymph vessels. Okay? So, next, no? Let's start with this question. A 54-year-old man has just dislocated his right hip. The physician is concerned about the integrity of the joint's blood supply. Which artery is the main blood supply to the hip joint? Okay, so yun lang yung question. Ano yung main blood supply to the hip joint? It's actually coming from the medial circumflex femoral artery. So majority of the blood supply of the head of the femur, it will come from the medial circumflex femoral artery. Okay, shown here. This is your medial femoral circumflex artery. Okay? However, in children, okay, there's also a foveal artery, no? Remember your ligamentum teres, okay? Or your ligament of the head of the femur. In children, it will allow passage of the obturator artery, no, to supply blood blood in the femoral head in children. Okay. So, moving to the muscles, we already discussed the anterior fascial compartment. Okay? Sige. Let's move on sa medial fascial compartment. Okay? So, the medial compartment of the thigh, so, includes gracilis, adductor longus, adductor brevis, adductor magnus, and obturator externus. Okay? So, as you see, all of them, no, are innervated by the obturator nerve. Okay, again, the common innervation of the medial compartment of the thigh, it's your obturator nerve. Okay, and then the common action of the medial compartment of the thigh is hip adduction. Okay, hip adduction. Okay, except for obturator externus, no? Except for obturator externus, which acts to externally rotate the thigh. Okay, next, your posterior fascial compartment of the thigh. So, it includes the biceps femoris, semimembranosus, semitendinosus, and adductor magnus hamstring portion. No? Collectively known as your hamstring muscles. Okay? Okay, next. No? Next point is the common origin of the posterior compartment of the thigh. Okay, it would be your ischial tuberosity. Again, common origin of the posterior fascial compartment of the thigh, ischial tuberosity. Okay, all of them are innervated by the sciatic nerve, no? Tibial portion of the sciatic nerve, except the short head of the biceps femoris. No? Because the short head of the biceps femoris is innervated by the common peroneal portion. Okay, common peroneal portion of the sciatic nerve. Okay, all of them will act to flex the knee joint. Okay, again, common origin, ischial tuberosity, common innervation, tibial portion of the sciatic nerve, except the common peroneal, except the short head of biceps femoris. And all of them will flex the knee joint. Okay? Sige, next. So, question, a basketball player fell on his left knee, resulting into pain and swelling. A fracture of the patella will result in difficulty in extending the leg at the knee joint, difficulty in flexing the leg at the knee joint, inability to extend the thigh at the hip joint, inability to flex the thigh at the hip joint. Okay, definitely not C, not D, no? Since patella has no effect on the hip joint. Okay, so saan siya magkaka-difficulty? Okay, knee flexion or knee extension? Okay, so the answer here is knee extension, no? Because your patella improves the moment arm of knee extension. Okay, so your patella, it's the largest sesamoid bone in the body, no? And by definition, a sesamoid bone is a bone that is formed within a tendon. Okay, so remember, your patella is attached to your quadriceps tendon, okay, and is attached to the patellar tendon for it to insert to the tibial tuberosity. Okay, so it lies within the tendon of quadriceps femoris in front of the knee joint. Again, triangular in shape. Okay, ayan, nabanggit na. So, let's talk about your knee joint, no? So your knee joint is articulation between the femoral condyles and the tibial condyles here. Okay? Together with the meniscus, no? Lateral and medial meniscus. Okay? So your knee joint is made up of the tibiofemoral joint. So articulation with the femur and the tibia, okay? And the patellofemoral joint, the patella and the femur. Okay? So your knee joint, tibiofemoral joint is a synovial hinge joint, while your patellofemoral joint is a synovial gliding joint. Okay, sige. Let's talk about the ligaments. No? So the ligaments in the knee, okay, so let's start with extracapsular. So you have the ligamentum patellae, already discussed, so continuation of quads, no, for the patella to be attached to the tibial tubercle. Then you have a lateral collateral ligament, okay? It's cord-like. And one thing about the lateral collateral ligament, it is separated from the lateral meniscus by the tendon of the popliteus muscle. So that's why hindi laging concomitant injury, no? Pag lateral meniscus LCL, no? You can have LCL injury without injuring your lateral meniscus. However, your medial collateral ligament, so it's a flat band, this ligament is strongly attached to the medial meniscus, no? That's why in some cases, pag may medial meniscus tear, okay, kasama na tear si MCL, no? Kasi they are strongly attached to each other. No, 'di ba gano'n naman? Pag na-attach ka, parehas kayo nasasaktan, tama? So si medial meniscus, pag nasira siya, nasisira din si MCL. Okay? It's actually part of the triad, no? We'll discuss later. So your LCL is here, lateral collateral ligament, from the lateral condyle to the head of the fibula. Your MCL is here. Okay, so that medial condyle to the to the upper medial tibia. This is your medial meniscus, no? Ayan, no, nakita niyo yung attachment na MCL attached siya sa medial meniscus. And you have the important intracapsular ligament, your ACL and your PCL. Okay? So your ACL, it is attached at the tibia at the anterior intercondylar area, no? And then it will pass upward, ito yung ACL, no? It will pass upward, backward, and laterally, no? To attach to the lateral femoral condyle. So it will prevent forward sliding of the tibia, so anterior translation of the tibia, or it could prevent the other way around, posterior translation of the femur on the tibia. Okay? It is taught during knee extension. So it can prevent hyperextension of the knee joint. On the other hand, your PCL, so your PCL is here, no? Nasa likod. Coming from the posterior intercondylar area of the tibia, so it will pass upward, forward, and medially, no? To attach to the medial femoral condyle. So, just the opposite of your ACL, it will prevent posterior translation of the tibia or anterior displacement of the femur on the tibia. Okay, it is taught during knee flexion, so it can limit hyperflexion of the knee. So clinically, common ways to injure your ACL, you will have blow on the lateral side of the knee. So it's a valgus force or hyperextension. Okay? Some special tests that we use, anterior drawer sign, Lachman test, and the lateral pivot shift test. Next, you have your PCL. Okay? Your PCL can get injured when you land on the flexed knee. No? A special test that can be used, posterior drawer sign. Okay, next, no? Let's talk about your meniscus. So your meniscus are C-shaped sheets of fibrocartilage. So just like your glenoid labrum or your acetabular labrum, okay, it has the same function, no? To deepen the articular surfaces of the tibia to receive the femoral condyles, no? And as we say, your medial meniscus, because it is also attached to the MCL, it is relatively immobile. Okay? Therefore, susceptible to injury. So, because MCL and medial meniscus are attached to each other, nasasakal siya, tama? So, pag nasaktan si isa, nasaktan din sila parehas. So, going to this point, no, your O'Donoghue triad includes, it will include letter A. No? So, your O'Donoghue triad, it includes rupture of the tibial collateral ligament, MCL. And again, pag rupture si MCL, sira din si medial meniscus. And to complete the triad, okay, your ACL is also torn. Okay, so that's the O'Donoghue triad. ACL, MCL, and medial meniscus. So ACL, okay, MCL, okay, and medial meniscus. Okay, mechanism of valgus, severe valgus force. Okay. So again, rupture of tibial collateral ligament, anterior cruciate ligament, and the medial meniscus. Tinanong to noong 2020. Next, now which of the following structures is inflamed in housemaid's knee? Okay, housemaid's knee. Patellar retinacula, infrapatellar bursa, lateral meniscus, prepatellar bursa, okay, or suprapatellar bursa. Okay, so that's your prepatellar bursa. Okay, so your bursa in the knee, it acts to decrease friction on the bone surfaces. So you have several bursa in your knee. Okay, starting with your suprapatellar bursa, no, as the name implies, it's superior, no, to the patella. Okay, located deep to the quadriceps muscle. Your prepatellar, it's located anteriorly or superficial to the patella. You have your infrapatellar bursa over the patellar ligament and deep to the patellar ligament, and your pes anserine bursa. Okay, at the insertion of the sartorius, gracilis, and semitendinosus. So your clinical correlation, no, when the for example, no, in housemaids, no, they frequently kneel, no, pag naglilinis sila ng floor, nakaluhod sila, no. So, ano nangyari? This bursa becomes in contact to the floor, no. In repetitive activities, repetitive kneeling causes it to get inflamed, causing a prepatellar bursitis. Okay? The next one is clergyman's knee, no? So, yung mga clergyman, yung mga, ano ba tawag sa kanila? Sa church, no? When they do genuflection, yung pag nagninil sila, no? This portion of the knee, okay, comes in contact to the floor naman. Okay? And repeated genuflection, okay, again, causes inflammation, eventually leading to infrapatellar bursitis, no? So, that's known as your clergyman's knee. Okay? And then, you can also have popliteal cyst or Baker cyst, no? Commonly associated with arthritis of the knee, meniscal injury, or tearing of the joint capsule. Okay? Sige. Next, no? The popliteal fossa, no? Let's go posteriorly. One concept then that was asked in the previous exam is your popliteal fossa. Okay? So your popliteal fossa is here. Yeah, no? It's a diamond-shaped space or depression. Okay? So diamond, meron kang 4 borders. Okay? So superolaterally, no? Superolaterally here. Ayan, okay? It is bounded by the biceps femoris. Okay? Can you follow? So, pero medially, okay, you have your semitendinosus and your semimembranosus, okay, in here. And then, inferomedially and inferolaterally, you have the 2 heads of the gastrocnemius muscle, forming the diamond. So, what are the contents? No? So, it will contain the termination of the small saphenous vein, the popliteal artery and its branches, the tibial and common fibular nerves, posterior cutaneous nerve of the thigh, and the popliteal lymph nodes and vessels. Okay, so there. Okay, moving forward, let's go to the leg. Starting with the tibia. Okay, your tibia is the large weight-bearing portion of the and medial bone of the leg. Okay, so your tibia is here. Okay, what are the features? You have your intercondylar eminences. So that's the attachment of your cruciate ligaments. You have your medial and lateral condyles that will articulate with the femur condyles to form your knee joint. Okay. Next, you have your tibial tuberosity here. Okay, so attachment to patellar ligament. Okay. Distally, you have your medial malleolus. Okay. Your fibula, okay, it actually does not take part in the articulation of the knee joint and provides just attachment for muscles. So your fibula is here located laterally. So you have the fibular head, okay? You have the fibular neck, okay? Wherein the common peroneal nerve winds around. Okay, and then the shaft here and the lateral malleolus. Next, which of the following muscles dorsiflexes the foot at the ankle joint? Okay. Letter A, peroneus longus. Letter B, tibialis posterior. C, tibialis anterior. Letter D, peroneus tertium. Actually, may correction ito. Okay? So, the answer here, dorsiflexion of the foot. Okay? Actually, letter C or letter D. Okay? Letter C or letter D. Correct nyo na lang. Okay? Either C or letter D. No? Both of them can dorsiflex the foot. Your peroneus longus, okay, it's a plantar flexor and evertor. Plantar flexor and evertor. Okay, PE. Your tibialis posterior, it is also a plantar flexor and, however, this one's an invertor of the foot. Okay, invertor of the foot. Tibialis anterior, it's a dorsiflexor and an invertor of the foot. Your peroneus tertius, it's a dorsiflexor and an eversion of the foot. Okay? So, however, sa question, dorsiflexion, so it could be tibialis anterior or peroneus tertius. Okay, so you have 4 compartments of the leg. 4 compartments of the leg. Starting with the anterior compartment. So, the muscles that belong to the anterior compartment include tibialis anterior, extensor digitorum longus, peroneus tertius, extensor lucis longus, and extensor digitorum brevis. Okay? Point of questioning. All muscles of the anterior compartment of the leg, okay, are innervated by the deep peroneal nerve. Deep peroneal nerve. Common action ng anterior compartment are dorsiflexion of the foot or extension of the toes. Okay? Dorsiflexion of the foot or extension of the toes. So, those are the points of question. Okay? Sa anterior compartment. Sa lateral compartment of the leg, okay, it includes peroneus longus and peroneus brevis. Okay? So, your peroneus longus and peroneus brevis has a common origin. Lateral surface of the shaft of the fibula. Common origin. Common innervation. Superficial peroneal nerve. Superficial peroneal nerve. Also, common action. Plantar flexion, eversion. Plantar flexion, eversion. Okay? Again, lateral compartment, peroneus longus, peroneus brevis. Okay? Superficial peroneal nerve, common action, plantar flexion, eversion. Okay, next. You have the posterior fascial compartment of the leg, further subdivided into a superficial group and the deep group. Okay? So, point of questioning then, all muscles of the posterior compartment of the leg, they are all innervated by the tibial nerve. Okay? All innervated by tibial nerve. Okay? So, superficially, it will include the gastrocnemius, plantaris, soleus. The deep group includes the popliteus, FDL, FHL, and tibialis posterior. Okay? Going to the foot. So, the bones of the foot, starting with the tarsals. So, you have the calcaneum, the largest and strongest bone of the foot. Okay? It has a shelf-like ridge on the medial surface of the on its medial surface, supporting the talus. Kaya siya sustentaculum tali. It sustents or it supports your talus. Okay? Your talus naman, on the other hand, it has a head, neck, and a body, wherein its head, it serves as the keystone of the medial longitudinal arch. Okay? One question here, your talus, it is the only only bone in the body with no muscle attachment. Again, sorry. Your talus is the only bone in the body with no muscle attachment. No? So, sana all hindi na attach. Okay, so these are your tarsal bones. This is your calcaneum or calcaneus, the largest and the strongest. This is your talus, again, the only bone without any muscle attachment. Okay, you also have a cuboid, which has a groove for your peroneus longus, and you have the cuneiforms. Okay, which contributes to the transverse arch of the foot. Okay, your ankle joint naman, it's formed by the lower end of the tibia, the malleoli, and the body of talus. So it is a synovial hinge joint. So the movements would be plantar flexion and dorsiflexion. Okay, so next question. Which joint is mainly responsible for the inversion and eversion of the foot? Okay, so that would be the subtalar joint. Okay, your subtalar joint. Okay, and then some other joints in your foot, you have the intertarsal joints. Okay, so your subtalar joint is a synovial gliding joint that can allow inversion and eversion. Okay, so all these joints are synovial gliding joints. All the intertarsal joints are synovial gliding joints except for the two. Okay, the talocalcaneonavicular joint, which is a synovial ball and socket joint. Okay, the talocalcaneonavicular is a ball and socket joint. Okay, and the cuboideonavicular joint, which is a fibrous joint. Okay, all the rest, they are synovial gliding joints. So, subtalar, calcaneocuboid, cuneonavicular joint, intercuneiform, cuneocuboid, tarsometatarsal, and intermetatarsal joints are synovial gliding joints. So, which of the following bones forms part in the transverse arch of the foot? Okay, calcaneum, talus, navicular, cuboid, or none of the above. Okay, so your calcaneum belongs to the medial and lateral arch. Okay, so your calcaneum belongs to the medial and lateral arch. Your talus participates in your medial arch as well. Okay, while your navicular participates in your medial arch as well. Okay, so the only bone that in the choices that participates in the transverse arch of the foot is your cuboid. So, okay? So, these are the arches of the foot. Okay? So, ito yung tripod ng foot mo, wherein the pressure of weight bearing occurs. Okay? So, your medial arch is here. Ayan. So, from posterior to anterior, you have the calcaneum, the talus. If you're navicular, okay, you have the three cuneiforms. And you have your first three metatarsals to form your medial longitudinal arch. Okay, your lateral longitudinal arch, okay, from here to here, the calcaneum. This is the cuboid. Okay, and then the fourth and fifth metatarsals. Okay? And your transverse arch will include all the bases of the metatarsal bones, okay, and the cuboid and the three cuneiforms. Okay, so all of them are included in your transverse arch. Okay, similarly to your brachial plexus, okay, maglabas ulit ng paper and let's try to draw your lumbar plexus. Okay? So your lumbar plexus, it's formed around or formed in the psoas muscle. Okay? And is comprised of the anterior rami of L1 to L4. Okay? But in the books, they include the subcostal nerve, no, in your lumbar plexus. But technically, hindi siya part, no, ng lumbar plexus. Okay? So starting with your T12 and L1, no? Your T12 and L1, it forms your iliohypogastric nerve. Okay? So your iliohypogastric nerve is a sensory nerve, no? Supplying your anterior part of the abdominal wall. Next, your L1 will give off an ilioinguinal nerve. So your ilioinguinal nerve will supply the skin of the groin, scrotum, and labia majora. Okay? L1, ilioinguinal nerve. Okay? The groin, scrotum, and labia majora. L1, L2, it will form your genitofemoral nerve. Your genitofemoral nerve. Your genitofemoral nerve is important in your cremasteric reflex, no? Your cremasteric reflex, no? Because number one, okay, it has a genital branch. Your genitofemoral nerve, it has a genital branch and then it has a femoral branch, okay? Your genital branch will supply the cremaster muscle, okay? Your femoral branch will supply the skin of the thigh. Skin at the upper medial thigh. So what happens, no? When you stimulate the skin of the thigh, no, upper medial skin of the thigh, no? So your sensory fibers will activate or will travel through the femoral branches of the genitofemoral nerve, okay? And in return, it will it will activate your cremasteric muscle, no, to contract via your genital branch of the genitofemoral nerve. Okay? Again, L1, L2, genitofemoral nerve, cremasteric reflex. Your L2, L3 will form your lateral femoral cutaneous nerve. So it will supply the lateral sensory to the lateral thigh. You have L2 to L4, okay, it will form the obturator nerve and your femoral nerve, okay? Your obturator nerve, again, it is the common innervation of the medial compartment of the thigh. So your adductors. Your femoral nerve is the common innervation of the anterior compartment of the thigh. Okay? So, another question, your femoral nerve is the largest branch of the lumbar plexus. Okay? It's the largest branch of the lumbar plexus. Okay? And lastly, your L4, L5, okay, it will form the lumbosacral trunk. No? It will form the lumbosacral trunk that will eventually join your your sacral plexus. So again, T12, L1, iliohypogastric, L1, ilioinguinal, L1, L2, genitofemoral, L2, L3, lateral femoral cutaneous, L2 to L4, your obturator and femoral nerves, and L4, L5, your lumbosacral trunk, okay, to join your sacral plexus. Okay, so this summarizes all the innervation. Okay, your sacral plexus, on the other hand, is formed in front of the piriformis, okay, and is formed by the anterior rami of L4 to S4. Okay, wherein your L4, L5 is coming from the lumbar plexus, no, which is your lumbosacral trunk. Okay, so in this part, lagi siyang by threes, no? By threes yung formation ng nerves. Okay? So by threes, starting with L4, L5, S1. Your L4, L5, S1 supplies your or will form your superior gluteal nerve. Okay, your superior gluteal nerve innervates gluteus medius, minimus, and your TFL, tensor fascia lata. Your nerve to quadratus femoris innervates your, of course, your quadratus femoris and your inferior gemellus. Okay, your inferior gemellus. Okay, so moving down, okay, so L5, S1, S2. L5, S1, S2, it will form the inferior gluteal nerve, okay, which innervates the gluteus maximus. Okay, it will also form the nerve to obturator internus. Okay, so it will supply the obturator internus and your superior gemellus. Okay, moving down, S1, S2, S3. Okay, S1, S2, S3. So, it will form your posterior cutaneous nerve of the thigh. Okay, so it will supply sensation at the posterior thigh. And then S2, S3, S4 will form your pudendal nerve. Okay, S2, S3, S4 will form your pudendal nerve. Okay, and then finally, L4, L5, S1, S2, S3, okay, will form the largest nerve in the body, okay, which is your sciatic nerve. And your sciatic nerve will eventually divide to form your tibial nerve and the common peroneal nerve. Okay, so to summarize, again, your sciatic nerve, the largest branch of the sacral plexus. It is also the largest nerve in the body. Okay, your supergluteal nerve, inferior gluteal nerve, okay na. Okay na to. Sige. Your pudendal nerve, it leaves the pelvis. Ito yung nerve na parang hindi siya makadecide, no? It will leave the pelvis through the greater sciatic foramen, no? Pero babalik siya, no? Through the lesser sciatic foramen, babalik siya to innervate the perineum. Okay, so that's your pudendal nerve. Okay, so this question was asked during our board exams. So, talking about the sciatic nerve. So, which of the following is an incorrect statement regarding the sciatic nerve? Okay, letter A. It is a sensory motor nerve. Letter B. It supplies all the muscles of the leg and foot. Letter C. It supplies the posterior thigh muscles. Letter D, it supplies no structure in the gluteal region. Okay. Letter D, none of the above. Okay. Actually, no. Letter C is correct, no? It supplies the posterior thigh muscles, like your hamstrings, diba? Your semimembranosus, semitendinosus, etc. Letter B is also correct, no? It supplies all muscles of the leg and foot, no? Through your tibial branch and your common peroneal branch. Okay, letter D is also correct. No? No structures were supplied in the gluteal region. Okay, it was just start supplying at the thigh or thigh na. No? It is also a sensory motor nerve. No? Through your tibial and common peroneal nerves. No? Meron silang sensory supply. So, the answer here is none of the above. Okay, so all of them are correct. So again, your sciatic nerve is L4 to S3 nerve roots coming from L4 to S3. This is the largest nerve in the body. Okay, again, no structures were supplied in the gluteal region, and it will start supplying the thigh, no, specifically the posterior thigh muscles, no, including the hamstrings, and all muscles of the leg and foot. Okay, distally, or it will terminate into two branches, your tibial and sciatic nerve, tibial and common peroneal nerve. Okay, the tibial nerve is the larger branch, okay, which further branch into three more nerves, the sural nerve, the medial plantar, and the lateral plantar nerve. You have the common peroneal nerve, okay. Clinical correlation, this is the nerve injured in fractures of the fibular neck. Okay, it is also the one being compressed when you apply a tight cast or a tight splint. Okay, it's the common peroneal nerve. Okay, your common peroneal will further subdivide into deep and superficial peroneal nerve. Okay, as we discussed earlier, no? So your deep peroneal will supply the anterior compartment of the leg, while your superficial will supply the lateral compartment of the leg. Okay? Some other branches, your sural nerve, okay, is a branch of your tibial nerve. Okay? It supplies the lower sensation to the lower posterior lateral leg. Okay? This is in contrast with your saphenous nerve. This is a branch of your femoral nerve, okay, and supplies the anteromedial and posteromedial leg. We'll see later. Okay, so in this picture, so you have the medial calcaneal branch of the tibial nerve. Okay, so it will supply the medial heel, the medial plantar nerve here, okay, and the lateral plantar nerve here. Okay, so it's supplying the plantar aspect of the foot. At the dorsum, okay, ito, no? The first web space is supplied by your deep peroneal nerve. Okay, the first web space is supplied by the deep peroneal nerve. Superficial peroneal nerve supplies the rest of the dorsum of the foot. Okay. As mentioned kanina, no, the medial side of the leg is supplied by the saphenous nerve, further extending sa foot, no. That's supplied by your saphenous nerve, which is a branch of your femoral nerve. And then laterally, lateral side of the foot, it's supplied by your sural nerve. Okay, so let's go to this question. A patient complains of waddling gait. A patient walks with a waddling gait that is characterized by the pelvis falling toward one side at each step. So what nerve is involved? Okay, so sa waddling gait, let's identify first which muscle is weak, no? So sa waddling gait, you have weak hip abductors, no? So that's your gluteus medius and your gluteus minimus. And these are innervated by your superior gluteal nerve. Okay? So parang sa upper extremity, okay, let's have a fast talk ulit, no? Fast talk with nerve injuries in the lower extremities. Okay? Starting with meralgia paresthetica. Okay? Meralgia paresthetica. Okay? Your meralgia paresthetica, okay, happens when you wear tight pants or tight belt, no? So nako-compress yung nerve at this level, okay? And the nerve that is being compressed is your lateral femoral cutaneous nerve. Okay? Remember anong counterpart niya? Ano yung chiralgia paresthetica? Okay? Chiralgia paresthetica. Okay, superficial branch of the radial nerve. Next, the nerve that can get compressed between the greater sciatic notch and the piriformis. Okay, that's your superior gluteal nerve, no? This nerve passes over or superiorly, no, to the piriformis, and it can cause compression at that level. Okay, natanong na, waddling gait, weak hip abductors. Weak hip abductors, okay? And the hip abductors are supplied by superior gluteal nerve, okay? When bilateral hip abductors are weak, you present with waddling gait. No? Waddling gait, bilateral weakness of hip abductors. Pero if it's unilateral, it is called the Trendelenburg sign. Okay? Still weak hip abductors, okay, can be caused by superior gluteal nerve injury. Hamstring syndrome, okay, your hamstring syndrome, okay, this nerve can get compressed within your hamstring muscle. Okay, it's actually the one that also innervates that muscle. Okay, so your sciatic nerve. Intragluteal injections, no? When you do intragluteal injections at the lower inner quadrant, you tend to compromise this nerve, no? So your sciatic nerve. Okay? So the safe level of injection must be at the upper lateral quadrant. Next, your piriformis syndrome, no? Ito naman, when the piriformis is hyperactive, okay? Or in cases, meron ka daw fat wallet syndrome, no? So may mga tatay na makakapal yung wallets, no? Nilalagay nila sa back pocket, no? So, nangyari, they compress this nerve, no? When they sit. Okay? So, that's the sciatic nerve. So piriformis syndrome or fat wallet syndrome. Fat wallet. Okay, next. Now, this nerve can get compressed under the inguinal ligament or at the femoral triangle. Oh, siya lang yung nerve doon, no? At the femoral triangle. Okay, your femoral nerve. Next up, nerve that can get compressed at the obturator foramen or obturator externus. Okay, so this nerve, definitely that will be your obturator nerve. Okay, nerve that can get compressed in your adductor canal. Okay, in your adductor canal. Dalawa lang yung nerves doon, remember? Okay, but the one commonly compressed at that portion is your saphenous nerve. Okay, it's your saphenous nerve. Next, ski boot syndrome. No? When patients wear a ski boot, no? It can compress the anterior tarsal tunnel, okay, sa dorsum ng foot. Okay, compressing the deep peroneal nerve. Okay, so when they wear ski boot, okay, or when they wear high heels, compressing causes narrowing of the anterior tarsal tunnel. Okay, they can compress your deep peroneal nerve. Foot drop was asked in the recent exams, no? Foot drop. Okay, foot drop is a manifestation of dorsiflexor weakness, no? Which is innervated by the deep peroneal nerve. Okay, so foot drop. And when they walk, they manifest with steppage gait, no? So they increase the hip flexion and they increase the knee flexion, no? Para hindi kaladkad yung foot. Okay, so it's a manifestation of the deep peroneal nerve injury. Next, wearing of tight boots. No, wearing of tight boots can cause compromise to the sural nerve. Andiyan na, no? Sural nerve. And then posterior tarsal tunnel syndrome. Okay, your posterior tarsal tunnel syndrome is wherein there is compression, no, at the posterior tarsal tunnel wherein the tibial nerve passes through. Okay, so posterior tarsal tunnel, it's the tibial nerve. Okay, so that's all for the fast talk. Okay, for the final part of the of the lower extremity, so let's go through the blood vessels. Okay, so for the lower extremity, partly na-discuss kanina, no? So coming from the abdominal aorta, okay, so it will branch to common iliac arteries. So your common iliac will divide into two. Your internal iliac will go to the pelvic organs. Your external iliac will supply the lower extremity. So under the inguinal ligament, it will become your femoral artery. It will pass posterior. It will pass sa femoral triangle, diba? Subsartorial canal, and it will go posteriorly to become your popliteal artery. Okay? And your popliteal artery will branch into anterior and posterior tibial artery, eventually your plantar arches. Okay? So, case, no? A 50-year-old male patient was noted to have cyanosis and decreased sensation of the left foot. And you decided to assess the dorsalis pedis pulse. Where will you palpate for pulsation? Okay? Medially to the EHL tendon or medially to the EDL tendon. Okay? Or in front of the medial malleolus or behind the medial malleolus. Okay? So your dorsalis pedis is actually between EHL and EDL. So between these tendons. Okay. However, it lies medially to the EDL and laterally to the EHL tendon. Okay. So another question about dorsalis pedis artery. No, maraming question about dorsalis pedis during our exam. So your dorsalis pedis artery, okay, can be palpated where? Okay? Is A correct? Beneath the flexor retinaculum? No, no? Dapat beneath the extensor retinaculum. Okay, so this pertains to the posterior tibial artery. Tama ba yung B? No? Behind the medial malleolus. Okay, again, no. Because it is it refers to posterior tibial artery. Tama ba yung E? No? Midway between medial malleolus and heel. Okay, again, it's incorrect. It refers to the posterior tibial artery. Letter D, between FDL and FHL, again, it's incorrect. Huh? It refers to the posterior tibial artery. Okay, so the one that pertains to the dorsalis pedis is letter C, between EHL and EDL. Okay, so saan mo paghahanapin yung mga artery mo? Okay, para pag ABG, hindi ka lang tusok ng tusok, no? So your femoral artery, it's behind the inguinal ligament, okay? And a point midway between the ascis and symphysis pubis. Your popliteal artery can be palpated at the popliteal space and better palpated with the knee in flexion. Okay. So, ito yung nasa question, no? Your posterior tibial artery, it's behind the medial malleolus. It's beneath the flexor retinaculum. Okay, between the FDL and FHL. Okay, and midway between medial malleolus and the heel. Okay, so this is your popliteal artery sa popliteal space. This is your posterior tibial artery, no? Beneath the flexor retinaculum, near the medial malleolus. Okay, and again, may star yung dorsalis pedis, no? Kasi lagi natatanong. It's between EHL and EDL. Okay, and between the medial and lateral malleoli. Okay, in front of the ankle. Okay, so this is your anterior tibial artery. Okay, next, a dehydrated 3-year-old has only one prominent vein which is located in the ankle. Okay, and in front of the medial malleolus. Okay, what vein is it? Okay, anterior tibial vein, small saphenous vein, posterior tibial vein, or great saphenous vein. Okay, so the one in front of the medial malleolus, so that's your great saphenous vein. Okay, so you have actually two saphenous veins. You have the great or the long saphenous vein and the small or short saphenous vein. Okay, your great or great saphenous vein, okay, it's located medial and anterior to the it is located anterior to the medial malleolus. Okay, so it's located medially. Okay, and it will drain into the femoral vein directly. In contrast, your small or short saphenous vein, it will drain into the popliteal vein. Drain into the popliteal vein, and it's posterior to the lateral malleolus. Okay, look here. Asan si medial, ito si medial, no? So this is your great saphenous vein. And as you track, asan siya, ang layo niya, okay, saphenous, it will drain directly to the femoral vein. Okay, in contrast, asan si small saphenous, no? It's here. Small saphenous from here, it will drain into the popliteal vein. Okay? So the one that we use is the great for access is your great saphenous vein, no? So great saphenous vein cap down. So under local anesthesia with saphenous nerve block, you do a transverse incision, okay, anterior and superior to the medial malleolus, no, to access the great saphenous vein. Okay, so that's all for the lower extremities.